Thank you for your continuous viewing. We will start the third session of the conference. Welcoming back Dr. Junaid Khan, chairing this session on neurology and neonates. Good afternoon, Dr. Junaid. The session is yours.
Good afternoon, everybody. And so far, we have two very fruitful sessions. And without further ado, it's my pleasure to introduce Dr. Ayman Rahmani, my friend, my colleague, and somebody, not somebody, everybody said my twin brother. So Dr. Rahmani is American board certified in pediatrics and neonatology, and he's currently serving as the chief of neonatology and Deputy CMO at the Hospital. He previously served as the chairman of pediatrics. Dr. Rahmani achievements include establish and expansion of neonatal care services at the Hospital, and he is one of the pioneers of this conference also. And we and him do a lot of educational activity. He's the lead role in neonatology for Abu Dhabi region, Al and Abu Dhabi region. Dr. Rahmani is graduated from Damascus and then is completed pediatric residency, is given BNJ from New Jersey and fellowship at Temple University Children's Hospital. He published extensively. He presented internationally in many international conferences. He did a lot of research work. I think if you go through it, he has a lot of accomplishments. He's a member of American Medical Association, AAP, American Academy of Pediatrics, and he did 100 communication, more than that, and that's a presentation in several international conferences. So today he's taking the topic of neurology, which is yet another important topic. So without further ado, Dr. Rahmani, please go ahead and tell us about neuronal integrative development care models. Thank you.
Thank you very much, Dr. Junaid, for the introduction. It's a pleasure to present my talk to this afternoon, and it's going to be different than the previous talks that we presented in the conference, in terms that we, as neonatologists, we really tend to be problem-focused, and we really good at to deal with each problem that comes out our way individually. My goal of this presentation is to put all this together in a model of care that we envision to put the care of the babies as a one program to improve the outcome and to decrease the morbidities that comes with the premature birth. Now, you may know most of the elements of this presentation, and I hope that you do, and you practice this in your hospital. But also, I hope that if there's something that I present here that can be beneficial to you, to kind of pay attention to, that would be a great accomplishment from this presentation. So why do we need a new integrated care model? We recognize that we have a improved survival over the years. From days when I was in training about 30 years ago, the survival of 25 weeks was questionable. Now we're talking about survival of 22 weeks, and I'll show you some data about this. And also Dr. Hamid Hassani will talk about those survivals in today's program. With this improved survival comes a price. The price is increased morbidities. So if we bring new care practice and benefit from research and evidence base to implement those and bring it to the bedside, that would be great things. we do a lot of things that is really not into the evidence base. But I think the more and more we have data, the more that we be informed about our decision to care for those children. So our goal is to improve the short and long-term outcome of these infants and their families. The most important things in the long term is the neurological disabilities. So if we can decrease the neurological disabilities that comes with the premature birth, and then that'll be a great accomplishment. Among these, we're talking about cerebral palsy, cognitive impairment, and epilepsy. My focus will be on a premature birth and especially on the extremely low birth weight infants. But if we implement those strategies, also full-term babies will be benefited from this program. So I'm going to have two sections of this presentation. Is that one of the first one is the short-term goals, and the other one is the long-term goals. So the short-term goals of neonatal care. What's the element of survival? So when we have a baby born at 22, 23 weeks, what's make the difference in the short-term outcome or survival? First of all, our intervention. So if we decided that we're going to resuscitate a baby who is 22, 23 weeks, that will increase the chance of their surviving. Also, as everything in life, the females are more advantaged than males, and among them in survival in extremely low birth weight infants. So being a female, that will give you more advantage. Antenatal steroids play a great role in the survival of the extremely low birth weight infant. And the clinical status at delivery, most of the death of extremely low birth weight infants happens around the delivery or the first few hours or days after deliveries. Also, the status in utero of those babies, so fetal growth status, IUGR, SGA, or normal weight, that affects the chances for survival. Just to give you an example of one simple thing that we do to increase survival. This is from JAMA 2011, and show you the use of antenatal steroids. We did very great job in the last 20, 30 years in implementing antenatal steroids. And those improvement or success really affect the 24 and 25 weeks, where the rate of antenatal steroids is close to 80%. To a lesser degree of 23 weeks. But if you look at the 22 weeks, you see a lot of variation. And there's a lot of debate going between neonatologists and OB colleagues about the use of steroids at 22 weeks. As we see here from the NICHD network, is that the use of antenatal steroid at 22 weeks is about 20% at the most. So if this can be improved, that will be increasing the survival. This is from publication in the American Journal of Obstetrics and Gynecology in 2021, which showed the survival of 22 weeks gestation when we are giving proactive treatment. As we see here, it's a very diverse group of patients. And if you look at the total number of patients of 2,226 patients, the pool effect of the survival is about 29%. So 29%, but if you look at the heterogeneity of these group, so in some centers, you see that is about 10% of babies survive, some of them actually 0%, some of them at 10%, some of them are really very good, it goes up to 6 or 7%, or it's at 60 or 70%. So the main, like, if you mix them all together, about 30% of babies born at 22 weeks survive overall in the in the first days of life. Of course, this is not really not all extremely low birth weight infants will have the same survival. The survival will improve when every week passed in utero. So if you look at the 22 weeks in the also in NICHD network that's published in 2017, you see that there's a slight improvement in the survival of 22 weeks, but it's still less than 10%. If you compare it to the 25-weeker, that's up to 80%, between 70 to 80%. So these are a critical period between 22 to 25 weeks that affects really the survival rate tremendously. We have to think about survival as not a static phenomenon. It's like a dynamic number. So the survival of 22 weeks at day 0 is completely different than survival of 22 weeks at 1 week or 1 month. If you see from these numbers here, that's also from same publication, 2017 NICHD network, you see that in a day 0, the chance of survival is about 15%. If the baby survived the first week of life, that's chances of survival goes to 45%. That's threefold increase. If you go to 1 month, then that's almost 80%. So that's also a double from the 1 week, and 4 times from the day, or more than 4 times from the day 0. So the more we can keep the babies alive in the NICU, the more chances that they will survive the first days of life. Also, that survival is variable between centers. This is from publication in 2019, which show if you compare, for example, the Japanese outcome to the Sweden and US outcome. In Japan, you have the 22 weeks surviving about 54%. The mortality is about 54%, where the mortality or death in the US grew from the time between 2008 to 2011 was 97%, so only 3%. If you look at 23 weeks, that death will decrease in the Japanese studies to about 27%, where in American studies will go 75%. Also, the neurodevelopment impairments in the Japanese is much less than the American studies. So there's a lot of variation across countries, but also if we talk not about survival, we talk about morbidity. Morbidity also is dynamic phenomenon, which is it's variable between the 22 weeks and the more mature babies at 24, 25 weeks. In the if you look, for example, in the Japanese neonatal research, and that's published this year in 2021 in Journal of Pediatrics, you can see that, for example, IVH in the Japanese studies, 22 weeks, is about 50%, where in 23 weeks will go down to almost 40%, and less to 10% in the 27 weeks. If you look at sepsis, sepsis in the 22 weeks is about 30%, where in 27 weeks will go down to almost 10%. And air leak in the 22 weeks will be around 10% in the 22, 23 weeks, where it goes down to less than 5% in the 27 weeks. So the morbidities and mortalities improve with the increased gestation, which is something that we already know about. So what's the consideration for offering care in a baby delivered less than 24 weeks? And Dr. Khasana will talk about more the ethical part of this question, but from clinical part, if we need to optimize the care of those 24 weeks or less, we need to have a good collaboration between the obstetric services and neonatology service to make sure that we're on the same page of the prenatal steroids or the mode of delivery and the care provided after the delivery. We need to include the parents on those discussions, because the parents are the most important caregiver for those babies for the long haul, for their much more time than the time that I only spent in the ICU. Also, we have to have a shared decision between us, the parents, and all the medical fields that involve in the care of those babies. We have to have the appropriate equipment to care for those infants. So this extremely low birth weight infant, 22, 23 weeks, are better served if they born in tertiary centers where they have all the equipment that available to the baby doesn't have to be transferred from one place or another for care. Also, we have to get the buy-in from our staff is that the care that we're providing for those extremely low birth weight infants is not futile. Those babies will have a future, will have a survival chance, and we need just to optimize their survival chance and decrease their chances for morbidity. And we need to track our outcome. We have an effort right now in all major hospitals in Abu Dhabi to look at our outcome for those babies in terms of survival, in terms of morbidity, and we'll share with everybody when we have those information analyzed. So moving to the second part of my presentation, which is the long-term outcome of this NICU care. And the main part of the long-term outcome, we'll talk about neurophysiological outcome. Now, if we look at the babies less than 26 weeks, and this is from publication in Pediatrics 2020, if we look at extremely premature babies, so to have an intact neurodevelopment, you will have about zero neurodevelopmental disability. So you see that only 40% of babies, extremely low birth weight infants, will have an intact neurodevelopmental outcome. This also affected term babies, but it's babies, full-term babies will have 80% chance not to have neurodevelopmental impairment. And for babies to have multiple neurodevelopmental impairments, you will see that premature babies will have more share than the full-term babies. What about IQ? IQ, if we compare the babies in extremely low birth weight infants, with the average IQ will be about 10 to 15 points less than the full-term counterpart. So if we aggregate all the IQs at 19 years of age, you will see that extremely low birth weight participants will have a much lesser numbers than the IQ of the term babies. Also, this is from a work of Dr. Wolk in UK, who worked in the IQ at 26 years of age. And he had a cohort of 359 patients. He followed until 26 years of age. And he compared the very low birth weight infants and the extremely low birth weight infants to control. And he found that on every aspect of the IQ test, the premature babies score less. In the full IQ test, in the verbal and the performance IQ. So this is why actually we need to maximize the potential for neuroprotection in newborn born at extremely low birth weight infants. So neuroprotection in ICU, and many units right now are implementing the neuroprotection units, which is maximize the potential for babies to survive without neurodevelopmental impairments. Recognizing that the fact that the babies have a fragile brain with earlier gestation. Now we have to have an effective, consistent neurodevelopmental directed care from the time of birth in order to protect those babies and optimize their development. We have to provide family integrated neuroprotective developmentally supported care, which include the most important part of this care, which is providing a healing environment for those babies, to offer a calming and soothing approach that will keep whole family involved in the care for those babies. Now, we can utilize some of the existing monitoring technologies to minimize the interruption of the care or the procedure that we can actually stress the babies with. We use them very now frequently in our unit. One of them is amplitude integrated EEG to look for seizure activities or to monitor brain activities. We have the near-infrared spectroscopy to allow assessment of oxygen level of the brain or other organs in the body without being invasive or doing blood tests and unnecessary blood drawing. We have non-invasive CO2 monitoring to minimize also phlebotomy. So we need to utilize these for extremely low birth weight infants in order to minimize the stress. So this is the concept I would like to introduce, is a neonatal integrated developmental of care. The center of this project is to providing a healing environment, which is protecting the baby's sensories. You have to protect the senses of the babies, which is the light, sound, taste, smell, and touch. Also, we need to optimize the baby's position in hand from the day one after the baby arrived from the NICU to protect their sleep, to minimize the stress or pain, to protect their skin and optimize nutrition. And also a very important part is to be partners with the families to deliver the care. So the center of this is providing healing environment. What we mean by healing environment is to protecting the sensory system of the babies. So sounds, I don't know how many of us will think about when we come and do rounds in the morning to speak in a very low voice, in a library voice when you do the rounds. How many of us will turn their phones off to vibrate during rounds so you don't have the ringing of the phone being amplified by the baby sitting inside the incubator? The lights, we have to protect babies' visual life. I would really like to request from you to, when you do rounds, look how many times we do procedure on the babies with the wide open eyes, that the baby staring at us. We need to have the baby's eyes closed during the procedures. We need a very bright lights to protect the baby's eyes during the procedure. We need to cover the isolates all the time to make sure the babies sleep without interruption. Smell, in time of COVID-19, when we have to use, a hand sterilizer or a sanitizer all the time, how many times we wait for the sanitizer to dry before we enter the isolate and then some of those sanitizers have a scent to them, and that can affect the baby's sense of smell. Also, we use perfumes, we use cologne. We need to kind of smell nice, but those smells can affect actually the baby's sense of smell. So there's some unit there is like really a ban on using cologne or perfume. Touch or movement. When we touch the babies, we need to make sure that we don't do sudden moves. So we move the babies very slowly. We use both hands. We sometimes use 4 hands, to do any movement. When we do a procedure, we need to go back and move the babies to a more natural position with a flex position. Skin-to-skin contact is in every core measure of all these healing environment. You're going to see it going again and again and again, because providing the most healing environment for the baby is the core of it, is skin-to-skin with the parents. I say parents, that means including the father and the mother. Environment of care also, involve how we do with our units, how we design our units. So the best design would have a private room where you have the parents sitting in the room most of the time, or at much time that they want, not to feel their burden on us. They involved in the rounds, they involved in the discussion about the care. We do cycle lightning, we have minimize the noise, as I mentioned before. So skin to skin, you see it going mentioned a lot of times during this presentation, because it's really shown by evidence that babies will have more kangaroo care, will have a higher Bailey and mental score, motor scores. You have a higher IQ, you have better brain complexity, more synapses, and you have, if you look at them at 2 and 4 weeks, you have more maturity than their non-kangaroo care counterparts. So we have to be careful when we move the babies. We move with both hands. When you do procedure, we have 4 hands. And when you do blood drawing, you need to bundle the blood drawing so we don't interrupt the baby so many times. In the core measure 2, partnering with the family, we have to be partners with the family. We have to make them feel welcome when they come to the NICU. We answer to their questions. We involve them in rounds. We answer their questions, and we know that they're going through emotional phase when they have a premature baby. So we have to expect them to ask us a lot of questions. We have to encourage them to have skin-to-skin contact with the babies. That's because that heals the wound of the interrupted bonding that they're supposed to have after the baby is born. Positioning babies, we have to maintain the head at midline position. In our hospital, we maintain the head at 72 hours at the midline position. This is very important when the baby is on a ventilator. So the ventilator tube will not move the head to one side or another. You have to be on midline. Also, we have to maintain the babies in the posture, which is simulate the womb or the uterus posture. In the tucked position, flexed. And when we handle the babies full term, we have to handle them very slowly. No sudden moves. We don't interrupt the baby's sleep if they're sleeping. And we, as much as possible, do skin-to-skin contact with the mother because that's a natural habitat for all newborn. In the sleep part, we should never waken up the babies from sleep unless it's absolutely necessary. We have to protect sleep status by minimizing the noise and light, as I mentioned before. And skin-to-skin also promotes sleep for those babies. In the core measure 5, it's minimizing the stress circuit. Providing healing environment, no noise, no light, no sudden moves. We use positioning and boundaries to provide babies containment. We don't leave the babies all arm extended, leg extended. We have to contain them. We have to do flex. If we have to do procedure, after we finish the procedure, we have to do the positioning. Any procedure that we do the sucrose. We have to give it 2 minutes. We have to understand the physiology, how it works, and what time is given for it to work before we do the procedure. We have to provide adequate analgesia for painful procedure, especially if you have any ET tube or PICC line or any procedure that's painful. And it's better to do the procedure. I know it's difficult sometimes, but if you do skin to skin during the procedure, that will really improve, will provide an extra analgesic effect. In protecting the skin, we have to monitor humidity level, and we maintain a high humidity level for 5 to 7 days after baby is born, because that minimizes the electrolyte disturbance and the fluid loss. We have to monitor nasal septum. We have to check the nasal septum, especially if baby have nasal bronchs. We have to protect it from being broken down by the nasal bronchs. We have to have also examined subtle skin many times. Among them is the oral mucosa, the diaper area for the candida fungal infection, and also skin to skin will have support the maturation of the brain and protect the whole environment of the baby. So optimizing nutrition is the last core measure. We have to explain to the parents that human milk is an optimal diet. We have to discuss the medical need. We discuss when they should pump, and we support the mother in early continuing milk supply. We provide ongoing breastfeeding education. We explain to the mothers things that can improve the milk supply, and among them is the also bonding and the skin-to-skin contact. We have to use cue-based. We have to understand when the baby telling us that the baby is stressed or the baby hungry. We don't have to wait for infants to be on certain hours to be fed. And that's more for the full-term babies and premature babies. And we have to be supporting breastfeeding prior to discharge. So neonatal nutrition is one major part for improving the outcome. I know we don't want to be very chubby, but having babies growing well, have a healthy brain growth also. And the optimizing nutrition for neuroprotection is optimizing protein, the essential fatty acids, and the mother milk. And also, we have to understand that infusion of milk through any apparatus that we do, we lose a lot of fats and a lot of nutrition gone through that way. So in summary, the guiding principle for integrated care is we have to support all infants in a critical period of growth, and understanding that the minute that the babies come to our unit are the time that we can affect the future, for long term. The babies, the care should be rational. We have to treat the babies as they are full human being and a person, and we don't, treat them like a patient. We call them, this is my people who work with me. They know that by second day we have to call the babies with the first names, and that's sometimes people think that's weird, but we really need to treat them like a human being, that they have their own unique identity. We do an exam with the babies, not to the babies, and we note the individual differences and preferences of each baby that they have. Emotional connection with the parents is essential for optimal care. Parents are the most important caregivers in their baby life for long term. We have to support parents, infants' attachment in every possible way in ICU, and we provide support to the parents in every way possible. Skin to skin, if you don't remember anything in the skin to skin is the thing that you remember. Skin to skin contact is most important fundamental form of neuroprotection care. The mother is a natural habitat for the babies. All skin to skin contact support all 7 of the neuroprotection core measures. So if you have to encourage the facilitate the skin contact whenever it's possible. With that, I hope that I give you some information about this program, and I hope that you implement this integrated care in your unit. And thank you very much for listening.
Thank you very much, Ayman. Really nice day-to-day talk. We are not taking care of all those things. Some of those things, yes, but most of the time not. And I received a few questions about that, which we will discuss in our panel discussion. So thanks, Ayman. It's my pleasure to introduce our next speaker, who is my colleague, friend, since long, Dr. Sayyid Ali Raza. He's now working in the same facility, Sheikh Shahdud Medical City, Abu Dhabi. He's a consultant neonatologist. After graduating from Pakistan, he moved to UK for post-graduation. He worked about 12 years in various positions in England. Did his training in neonatology from southwest of England. After having worked as a neonatal consultant for a few years, he joined Mafra Hospital and then now Sheikh Shahdud Medical City. He has developed interest in pediatric cardiology and neonatal mechanical ventilation. He is also a part of our core faculty of pediatric residency program and extensively involved in teaching and quality projects in the department. He's very much doing experience in doing the neonatal echo. So, Dr. Sayyid Ali Raza, it's my pleasure to have you. He's going to talk about post-hemorrhagic ventricular dilatation, when to intervene. It's yet another some controversy around this topic. Dr. Ali, over to you. Thank you, Zandy, again. Sorry about some technical difficulty, you can expect it, but Dr. Ali will join us after Dr. Suma. So again, it's my great pleasure to introduce Dr. Suma B. Hoffman, Associate Professor of Pediatrics at George Washington University. She's MD, MS, and both are undergraduate from BS in Public Health, Nutrition, and Medical degree in the University of North Carolina at Chapel Hill. Right now, she is in George Washington University Hospital. From 2012 to 2020, she was an assistant professor of pediatric at the University of Maryland School of the Medicine, where she worked as a neonatologist in level 4 NICU. Dr. Hoffman is now an attending physician in Children's National Neurology Division. She is the Associate Director of Clinical Perinatal Fellowship. Dr. Hoffman's primary research focus is in evaluating hemodynamic status in neonates and relationship to both short-term and long-term outcomes. She utilized this near-infrared spectroscopy to non-invasively measure renal tissue perfusion. And this topic is very near to me as in my previous job I'm using since a long time. So I love to hear about near infrared spectroscopy in neonates clinical utility. So over to you, Dr. Suma Hoffman.
Good morning or afternoon, everybody. My name is Suma Hoffman, and thank you, Dr. Junaid, for that lovely introduction. And my hope is that we, by the end of the presentation, will decide whether or not there is a role for NIRS with respect to the clinical utility in the NICU in real time. I have no relevant disclosures. And my objectives for this talk, I want to briefly review near-infrared spectroscopy technology and techniques. I want to review the normative reference data for cerebral NIRS specifically, and review current areas of NIRS research with a focus on cerebral monitoring, and then discuss the clinical utility and feasibility of NIRS monitoring in the NICU. So, as you heard in the previous presentation, there really is a need for cerebral monitoring in newborns. We know that this is a population at risk. They're at risk for intraventricular and intracranial hemorrhage, ischemic injury, periventricular leukomalacia, adverse neurodevelopmental outcomes. And then, specifically, we have our preterm infants that are at high risk, but also in our full-term babies, those that have hypoxic ischemic encephalopathy, hypoxic lung injury requiring ECMO, and then our congenital heart disease population. And so though we have wonderful technology in terms of imaging, all imaging is a snapshot in time. And what we're hoping to do with both our bundled care and our active monitoring is to identify infants at risk before injury happens and adjust our care accordingly. And so this is where NIRS technology comes in. But before we can use NIRS technology, we want to understand a little bit more about how it works. So what does NIRS measure? So NIRS is near-infrared spectroscopy. It's based on the modified Beer-Lambert law about how light is altered through the material it's traveling through. It utilizes absorption of light in the near-infrared spectrum, which is 700 to 900 nanometers. And in the spectrum, it's transparent to skin, bone, and connective tissue. And so what we end up with is a venous-weighted oxygen index of the tissue beneath the probe. And unlike pulse oximetry, it is not reliant on pulsatile flow. Commercial algorithms available use the difference between oxygenated and deoxygenated hemoglobin. And so what we end up with is a measure of oxygen uptake in the tissue bed reported as regional oxygen saturation. I'll describe it here as RSO2, but when you're looking through the literature, you may see it described in various different abbreviations. We also have seen that RSO2 can be a surrogate for cerebral blood flow with some assumptions. There needs to be stable metabolism and oxygenation. We can also combine NIRS measurement with pulse oximetry measurement to allow for identification of oxygen extraction in the tissue bed being measured, which is FTOE, with this formula as seen here. And so in this figure, you'll see that the NIRS relies on a light emitter and then two detectors, a proximal and a distal detector, to give us the information that we are looking for. And then in terms of devices available, there are lots of different devices depending on where you are in the world and what's commercially been approved. In the literature, you'll see that the most common devices are the Invo's 5100C, the Neuro by Hamamatsu, and the Foresight. Those are the three most commonly seen, and those are the ones approved in the USA. We also have studies out of the EU using the Oxycram, the SenSmart, but you know what? Regardless of the device being used, what I think is important to understand is that though there is generally good correlation between devices, the differences in algorithms between the devices preclude comparison of the absolute measurements, or that should be done with some caution. Even within the same device, if different sensors are being used, that can lead to different reading between the sensors. So it just to be aware of as you are deciding when to use NIRS, what to use, what sensor to use, and as you're setting your goals for the NIRS measurements. And in order to use NIRS clinically, we need to know what normal is. And normative data sometimes can be hard to come by, especially in the full-term healthy population, which would be the reference population. So in adult and pediatric population, it has been referenced that cerebral NIRS generally should be within 60 to 80%, with somatic measurements, which is renal, splanchnic, smooth muscle, should be around 5 to 15% above cerebral values. But is this the same in full-term healthy infants? It's a hard population to study because they're healthy. They generally aren't staying in a hospital setting where NIRS is available. But Bernal and colleagues in 2010 did do a nice study looking at 26 full-term healthy newborns that he monitored for up to 5 days. And what they found is that generally there's similar correlation to the above measures, with cerebral means being around 78% plus or minus 9%, and somatic, and they used perirenal saturation monitoring, was approximately 10% higher, just as noted above, and plus or minus 8%. They also noticed that over postnatal days, there is a decline over time. So the values generally start high, and as metabolism increases, we see a decline in the oxygen saturations, likely due to increased oxygen extraction. But what about premature infants? And we're lucky because these are babies that stay in the hospital, so we have the ability to monitor them for longer periods of time. And there was a very nice study of nearly 1,000 preterm infants, less than 32 weeks, and they established reference curves. And they did this in 2-week increments. So here I show an example of the reference curve for 24 to 25 weeks gestational age. And so as you can see, at time 0 postnatal age, the mean is approximately 63%, and then peaks around 36 hours of life, and then declines back to that initial baseline. But overall, generally, you can see that the values for cerebral NIRS are relatively steady. What we don't see that we saw in the full-term population is that steady decline over time. We also know from the study that values increase by 1% per week of gestation. There are higher values in babies who are growth restricted and in males. And that when they compared sensors, specifically one of the devices used the Invo's device, when they compared the adult sensor to the neonatal sensor, based on the algorithms that were used commercially, had values that were about 10% higher. So this needs to be accounted for when you're comparing data. But what about somatic saturation? There really, when looking through the literature, there isn't a lot of data. So this is as of yet, unpublished data that I've put together of 57 infants less than 30 weeks. And what we note here is similar to what was seen in full-term infants for somatic saturations, is there's a steady decline over time. So initially, the median saturation is just over 80%, which is significantly higher than the cerebral saturation, and there's a significant decline over time. One thing that we do know is that the confidence interval in somatic saturation is wider than that in the cerebral saturation. It was approximately a 30% spread in the cerebral saturations, whereas here in the somatic saturation, you can see anywhere from 40 to even up to 50% by the end of monitoring. And so we can see that this is a tissue bed that has higher variability. And the decrease may be related to the increase in renal activity over time and may coincide with that diuretic phase that we see in most of our preterm infants. So moving on to some cerebral near studies that we've seen in neonates. So this won't be an exhaustive list because of the time here, but I want to highlight some of the important studies that have been done. So what we really want, going back to the very first slide, is what we're trying to prevent. We're trying to improve our outcomes with respect to brain injury. And so can NIRS be associated and be a biomarker of impending brain injury? And so what Alger Listing's group hope to do is look at 30 cases compared to control and with very routine IVH monitoring every 12 hours. And so what they found is that prior to detection of IVH, there was a significantly higher median value of RSO2 as compared to normal controls. About 5% difference, 70% versus 65%, which may be a decrease in oxygen extraction prior as there is impending injury prior to the bleed. Interestingly, after the bleed happened, there were no significant differences noted. And so, and this is looking at that CFTOE, which is the oxygen extraction. And so you can see that the decline, there is a decline in the oxygen extraction prior to the development of IVH. So this may be something to pay attention to as we are looking in the future to use this as active monitoring. Overall, in the literature, associations with brain injury have been mixed. However, I think there is a lean towards a positive association, with generally infants with brain injury having higher saturation levels, likely due to decreased oxygen utilization in that tissue bed. And thinking about prevention, is there a way that we can use NIRS to help guide our clinical management? And so I did this study looking at nearly over 1,000 arterial blood gases with corresponding cerebral saturation data. And because we know that increased CO2 fluctuations are associated with brain injury, increased CO2 causes relaxation and vasodilation of the cerebral vascular bed. Small changes in CO2 can have a large impact on the cerebral blood flow, with up to a 30% change for 1 kPa or 7 millimeters of mercury. And so when we look at the RSCO2 percentage over CO2 categories, and I categorize these as generally low, normal, permissive hypercapnia, and high. And if you look, it's generally steady right around 70% until we exceed a CO2 of 55 millimeters of mercury. And at that point, we see a 5% increase in cerebral saturation, similar to what was noted prior to the development of IVH. And so as we are looking at continuous monitoring, if we don't have continuous non-invasive CO2 monitoring, if we see a change in our cerebral saturation, then it will give us a clue of we need to look and see what our ventilation is. Do we need to adjust our ventilator? Do we need to change our mean air pressure? Are we ventilating too much, not enough? So there's definitely areas where we can improve our management. And then another major focus of NEARS research has been in cerebral autoregulation. So we know that cerebral autoregulation is the maintenance of a stable cerebral blood flow despite fluctuations in perfusion pressure. This protective mechanism is often impaired in preterm infants. In studies, up to 40% of the time of preterm infants can be spent with impaired cerebral autoregulation. Here we see a nice autoregulatory plateau, below which we know that there's increases risk of ischemic injury, and above which the cerebral tissue is vulnerable to blood pressure spikes and hemorrhage. And we can actually measure cerebral autoregulation using simultaneous cerebral NEARS, as mentioned earlier, as a surrogate for cerebral blood flow and blood pressure monitoring. And more recently, heart rate monitoring has been used as well. So looking at cerebral autoregulation, this is a busy slide, but this is a study that we did in 61 preterm infants. And we looked at the percent time spent with impaired cerebral autoregulation. So in order to do this, there's many different ways that people have studied cerebral autoregulation and techniques, which is beyond the scope of this talk. But we use correlation analysis using a cutoff of a positive correlation of 0.5 to indicate impaired autoregulation. And so in the black, you can see impaired autoregulation. And I have three groups, one with no short-term adverse outcome, those with IVH, and those who died. And so you can see in the group that had no adverse outcome, they spent initially about 19% of their time with impaired regulation. And over the 4 days of life, that decreased to about 14%, which was a significant decline in impaired regulation. Whereas those that with injury either stayed steady or increased their time spent with impaired autoregulation. There's also the concept of reactivity, so very reactive vasobed, so where there's an inverse relationship between blood pressure and cerebral saturation, which would lead to a negative correlation. And similarly, we see that there's increased reactivity, which is in this light gray bar, over time in the non-impaired group. So we see that they become less impaired and more reactive to their environment. And we know that there's risks of impaired cerebral autoregulation, and many thought that this is due to abnormal blood pressure, especially in the perinatal transition zone when the risk of injury is so great. So looking at cerebral autoregulation and blood pressure, Sol and colleagues noted that increased pressure passivity or impaired autoregulation when the blood pressure was less than the 10th percentile for gestational age. Gilmore and likewise Hahn found a increasing magnitude of impairment in cerebral autoregulation with decreased blood pressure. So this is Cox, which is a correlation type analysis looking at impaired autoregulation. And similarly, they used 0.5 as a cutoff. And you can see as the blood pressure subsequently drops, you get an increasing trend towards impairment, which is something to take notice of. But what can we do with this information? So one thing that we can do, because we don't have great definitions of blood pressure, is we can use NEARS to potentially define optimal blood pressure in the idea of individualized monitoring. And so here, using heart rate combined with tissue oxygen saturation or NEARS, we see that there's this U-shaped curve where at the optimal value, we'll see the most negative value, where they're the most reactive. This is the most active blood pressure for this particular infant. And similarly, their colleagues Mitra and DaCosta also found that for preterm infants, we can identify this optimal blood pressure. And in studies with both preterm infants and with infants with hypoxic ischemic injury, it has been shown that spending time outside of your optimal blood pressure increases the risk of adverse outcomes. Now, how else can we use NIRS? So one of the big debates in neonatal care has always been the detection of the PDA and what to do with the PDA. And so we know that infants with large hemodynamically significant PDAs are at risk for decreased tissue perfusion. This is generally thought to be secondary to the left to right shunting away from the systemic circulation. There is mixed evidence to support the ability of cerebral saturations to predict significant PDA, and many have suggested that a combination of cerebral and somatic measures may be more predictive, as the renal measurements, as we see clinically with a significant PDA, are impaired before cerebral saturations. However, this next study by Lemmer's group in 2016 showed controls compared to those that were treated with either indomethacin and surgery. And they found that RSCO2 measured prior to closure, and there was a significant decrease prior to closure as compared to control in both the indomethacin and even more so in the infants requiring surgery. And then they looked further at what this means for the developing brain. And they found a significant correlation between these values of cerebral saturation and cerebellar volume. So the lower the pre-closure cerebral saturation, the lower the cerebellar volume, which then leads to developmental disabilities later on. And then blood transfusion is another area in which there's debate. Do we use high goals? Do we use low goals? And using NIRS to look at tissue perfusion, specifically cerebral perfusion with varying hemoglobin levels, we generally see a decreasing cerebral NIRS saturation with increasing anemia. And we have noted in several studies that PRBC transfusion increases cerebral saturations and decreases the tissue oxygen extraction and calms that tissue bed. Though these changes may be transient, it is striking here. It's hard to see, but this is a hemoglobin of less than 6. You can see that 1 hour and 24 hours after transfusion, there's a significant increase in cerebral saturation after the transfusion. Similarly, increases noted at levels of 6 to 7 and greater than 7, but none so striking as when the hemoglobin is so low. And then other populations, a lot of research has been done in hypoxic ischemic encephalopathy, and we have seen that higher cerebral saturation values during the first 24 hours of life have been associated with increased risk of brain injury. Infants with adverse outcome are more likely to have impaired cerebral autoregulation. And then combined with somatic and EEG monitoring may have increased value. And here you can see the infants without brain injury and those with, and you can see in this first 24 hours, there's that decreased oxygen utilization in the brain here. And then taking all of this and looking at prospective management, and that's what we want to do. We want to take this from, observational studies and looking back at the data to can we actually incorporate this in real time. And so Pitchler's group is looking at cerebral oxygen saturation to guide delivery management. And in this small initial pilot study, they found that randomizing to NIRS in the DR decreases the burden of cerebral hypoxia in the delivery room. However, they did not see any difference in short or long-term outcomes, but they were not powered to do so. And so currently they're undergoing a multinational, multi-center trial, randomized control trial to look at this on a larger scale. And then one of the most well-known studies for cerebral NIRS is the SAFE-BOOST-C, where they randomized 166 ELBWs in the first 72 hours to NIRS monitoring. And they had a saturation goal of 55 to 85%. And they did show a decreased burden of hyper and hypoxia in the group, the intervention group. But unfortunately, there was no difference in clinical outcomes. And so they also, too, are conducting a larger study to see, to increase their powers. They weren't powered for those outcomes. But you can see that in the NEARS group, they kept a tighter range of cerebral saturation. And then can maintaining stable cerebral saturations improve hemodynamic stability? So they monitored 98 infants randomized to NEARS or standard care, and they found that the decrease in hypotensive burden was not significant, and there were increased echo evaluations and interventions in the NEARS group. So I think this, opens a little bit more question of that utility. And then as a real-time trend monitoring, this is from the Journal of Critical Care and looking at an infant with congenital heart disease. And you can see here, they noted mediastinal tube bleeding and then decompensation. But you can see here, both the the somatic and cerebral saturations were dropping at least 15 minutes prior to this event. And similarly, here, when the sternum was closed, you can see a very significant drop in the somatic saturation, which was increased with resuscitation. So the main thing to note is, what do we do with these numbers? If we have NEARS monitoring, but nobody pays attention to it, nobody does anything with it, then there's no utility in it. So with the SAFE-C trial, they had a very stringent treatment guideline. So when the saturations were low, they were instructed to assess cardiovascular status, potentially obtain echocardiographic imaging, consider treating the PDA, assess for anemia, assess their mean airway pressure. And similarly, when the saturations were above the limit, they looked to assess their respiratory status and assess their blood glucose levels. And so whenever you're thinking about incorporating NEARS, there are multiple considerations for routine use. So the cost, it's expensive technology, and so it may not be feasible for all institutions. There is increased monitoring burden and alarm fatigue. So going back to the previous talk, we're trying to be very gentle in what we do to these tiny babies, and putting multiple sensors, which can interfere with care, is that helpful? And then real estate. So this is a picture from a review by Marin and colleagues, and you can see these sensors are relatively large, even the smallest sensors for imagine an ELBW baby with this many sensors, along with their umbilical lines and their EKG leads. And so it really becomes that the baby is then covered with sensors. There also has to be staff education regarding notification and treatment guidelines, so that they know what this means. What do these measures mean? What am I looking for in my shift? So I think education is extremely important in using this in real time. And then improving real-time monitoring. So you want to have individualized patient monitoring and goals. You want to be able to incorporate a visual trend display in a user-friendly format. Right now, if it's in a small box off to the side and nobody's paying attention to it, it's not as useful. And how is it incorporated into our medical record and charting? And then ideally, what we should do in utilizing this technology is the creation of algorithms as an early warning sign and to guide an approach to care. What I envision is having real-time knowledge of changes in cerebral blood flow and autoregulation, and potentially a green, yellow, red zone. So if they're in the red zone, avoid any elective procedures, avoid blood draws at that time, be hands off. Versus, if they're in the green zone, then that's the time for cares. So just going to that gentle patient care and individualized monitoring. So in conclusion, I think NEARS should be incorporated thoughtfully into patient care. Keeping in mind monitor fatigue and sensor burden, there should be clear saturation goals, absolute values that's similar to the safe foods, but also trend monitoring, because if you go back to the studies, many of the differences were within that wide range of values. And education on treatment algorithms is essential, and then you need to reevaluate the use of guidelines regularly. And these are my references, and thank you so much for the opportunity to share my thoughts with you.
Yeah, thanks a lot, Dr. Suma Hoffman. Very interesting topic, very near to me. As I told you that we are using it for a long time in my previous workplace, and now to establish and to bring this technology in my new workplace also. There's a lot of questions. It's a new technology for this region. We will going to talk about it, and I need you for the panel discussion. Having said that, we are able to get Dr. Ali back, and I already introduced him. Dr. Ali was as a consultant neonatologist, presently working with us in Sheikh Shapoor Medical City, and he's going to talk about yet another very interesting topic of neurology is the post-hemorrhagic ventricular dilatation, when to intervene. Over to you, Dr. Ali.
Thank you very much, Dr. Junaid, for giving me this opportunity. Today I'm going to talk about post-hemorrhagic ventricular dilatation management in preterm infant. And the objective which I have got is really, I just want to identify what's the current practice of management of post-hemorrhagic ventricular dilatation at international level. And then I want to discuss the evidence behind this clinical practice. I have also tried to get some information about the ongoing local clinical practice and then comparing it with current international clinical practice and what we can do. We all know that severe intraventricular hemorrhage is it affects about 15% of extremely preterm infants, and about 1/3 to half of patients with IVH do develop post-hemorrhagic ventricular dilatation. And then again, about 1/3 of this progressive post-hemorrhagic ventricular dilatation, they do need intervention at about 35 to 40% of this group of patients. But presently, there is no any consensus about the management of this this difficult area of management. Before I go into further details, there a one slide about the intraventricular hemorrhage. Now, there are 4 grades of intraventricular hemorrhage. The grade 1 is subependymal bleed. There is no much bleed within the ventricles, but in grade 2, you can see the blood clots within the ventricles, but the ventricles are not filled with more than 50%. Whereas in grade 3, you can see the intraventricular bleed clot very obvious, and it will be filling the ventricle more than 50%, and the ventricles may or may not be dilated. Whereas the grade 4, which is more termed as post-hemorrhagic parenchymal infarction rather than grade 4 IVH, where the bleed is seen in the brain parenchyma. Usually the hydrocephalus is about abnormal buildup of CSF in the ventricles of the brain. And physiologically, the head circumference or the brain growth happens about 1 millimeter per day between 26 to 32 weeks. And after that, the growth slows down a little bit, about 0.7 millimeter per day up to 40-week gestational age. Enlarging ventricles within the brain, we can measure them by measuring the anterior horn width and the ventricular index on the cranial ultrasound scan. Whereas the interior horn width is the diagonal distance between the two walls of the lateral ventricles, whereas the ventricular index is the distance from midline to the lateral wall of the lateral ventricles. And these measurements are usually done on a coronal view at the level of the third ventricles. Once we have done the ventricular index measurement, they are usually plotted on the Levine chart. The dashed black line indicates the average ventricular index, whereas the dashed red line is indicating the ventricular index at 97th centile. This is the point where we really start monitoring the height of the ventricular dilatation more closely. Whereas this solid red line is showing the ventricular index at 97th centile plus 4 millimeter. And this is the point where people start intervening or start to drain the CSF from the ventricle because the ventricles are too much dilated. Whereas the interior horn width, which we have measured on the cranial ultrasound scan, is plotted at the Davis chart. This interrupted or dashed black line is indicating the mildly dilated ventricles, whereas the anterior horn width at the level of the red line showing the moderately dilated lateral ventricles, and the solid black line is showing the severely dilated ventricles. There are ways to monitor and decide about intervene when the ventricles has dilated post-hemorrhagically. So we can use the head circumference measurement or ultrasound ventricular dimensions measurement, which we do like measuring ventricular index and anterior horn width, or we can look at the clinical signs of raised intracranial pressures. And then one option is you use them all together. So these are the different ways of monitoring the ventricular dilatation. And people have tried to look at the relationship between the intracranial pressure and the ventricular size. And what they have found is that there is a positive relation between the ventricular size and the CSF, but it has not got much association with the clinical signs. And the reason behind is that usually the CSF pressure is around about 9 millimeter mercury. It starts increasing the ventricular size, but the clinical signs usually come up when the CSF pressure goes up to around about 15 millimeter mercury. And similarly, they did not manage to find any relationship between head growth and the CSF pressures. People have also tried to look at the relationship between the head circumference and the ventricular size measured on cranial ultrasound scan. And they could not find a relationship between the head circumference and the ventricular measurements done on cranial ultrasound scan. And the reason possibly is the brain parenchyma in these preterm infant is really very, very compliant. And then there is a lot of extracerebral space available. Coming to this review article, which was published in 2012, the author, Andrew Whitelaw, he recommended that at the moment the standard and the widely used approach is to use the ventricular tap, to use the ventricular reservoir device to drain the ventricle. It is quite standard and widely used approach. And in this approach, the intervention is decided by clinical signs suggestive of raised intracranial pressure, and then the ventricular measurement, which is done on head ultrasound scan. It is followed by doing the LPs, and if the patient needs more than 3 or 4 times LP, and the ventricles are still getting bigger, they use the ventricular taps. And at this stage, they usually put the ventricular access device. And they have seen that this approach is quite okay or appropriate for extremely low birth weight infants, less than 1 kg, and in the neonatal setting. In the same review article, they have discussed about other management approach to post-hemorrhagic ventricular dilatation, like use of diuretics to reduce the CSF productions, but it has not been spotted very well by the randomized controlled trials. And then coming to the intraventricular fibrinolytic therapy, or is the part of a drift trials, but in order to implement that approach daily, you need very skilled settings. So it is not easy to implement in a neonatal setting. And the other approaches like external ventricular drain, ventricular subclavian shunt, or third ventriculostomy, or choroid fluxus coagulation. There is no much lot of evidence behind these different approaches to drain the CSF in post-hemorrhagic ventricular dilatation. And in around the same time, a center published their experience of managing such patients who has got post-hemorrhagic ventricular dilatations. And they published their experience over the 20 years, and they were about 295 patients. A majority of them were preterm and significant IV and having significant IVH. These were the same patients which we are coming across in our neonatal unit. And they were treating them with temporary treatment with lumbar puncture or puncture from the ventricular reservoir, which was inserted. What they have found that ventricular reservoirs was inserted in about 73% of patients, and the overall infection rate was quite reasonable, about 6%, and the VP shunt was inserted in about 1/3 of the total cohort. So they have a good experience of managing such patients, and the same group really they published one article which was more a running commentary where they were doing the amplitude integrated EEG or the visual evoked potentials before and after insertions of ventricular access device. But they were trying to reproduce the same results which were claimed by another group of investigators. But they were not successful. And what the people were recommending that we should do not do intervention only when the infants are symptomatic in case of post-hemorrhagic ventricular dilatation. We should consider ventricular index measurement when it is 97 centile plus 4 millimeters. And the intervention should be aimed to reduce the ventricular size down to normal limits. And the test should not be performed just to relieve the raised intracranial pressure. In order to have a little bit bigger picture that what's happening at a bigger scale, then this survey was completed across Europe, where they tried to find the diagnosis and treatment approach of post-hemorrhagic ventricular dilatation. And they did that survey with the help of a questionnaire, and they contacted about 32 neonatal intensive care units across 17 countries. And what the nutshell was that yes, the diagnostic and therapeutic approach to manage this PHVD it does vary, but the majority of the center initiate treatment once the ventricular index has crossed the 97 centile plus 4 millimeter. And when we see this study having a closer look, that there were about 7% of the patients were having severe IVH, like grade 3 and grade 4. And about half of them developed a post-hemorrhagic ventricular dilatation. And then really 1/3 did not need intervention, and about 2/3 required intervention. And if we see what the diagnostic criteria they have used, most of them were using ventricular index reaching more than 97 centile. But some units were also using when the ventricular index was more than 97 centile plus 4 millimeter. And if we look at what was their criteria to start intervention, there were two major groups. Either they were doing early intervention or they were doing later intervention. Where early intervention means that they start draining the CSF from the ventricles when the ventricular index is at 97 centiles or taking other measurements. Whereas in late intervention, most of the people who are draining CSF or start intervening it when the ventricular index is 97 centile plus 4 millimeter. Or some centers were doing it when it is associated on top of that when the patient is having clinical signs suggestive of raised intracranial pressure. In terms of treatment modalities, daily, the most of the people were using the same kind of approach which I mentioned in the review article, that they were starting with the lumbar puncture and then they were doing ventricular tap, and then they would insert if it need more frequently, then they bring up ventricular reservoir, and then if it continue progressing the ventricle size, then they can use ventricular peritoneal shunt. There is a group of investigators who were using the drift trials, but obviously you can see it is being practiced only in 2 units, so it is not easy to implement. And then in another study, people have tried to look at the outcome of patients having post-hemorrhagic ventricular dilatation, and in this group, they looked at the outcome of patients less than 26 weeks gestational age, and really they divided them into three main groups. Either they were having post-hemorrhagic ventricular dilatation seen on a head ultrasound scan, or they have got intraventricular hemorrhage, but the ventricles are not dilated, or they do not have the intraventricular hemorrhage. And the conclusion was that post-hemorrhagic ventricular dilatation was associated with high rates of death or impairment among infants with gestational age less than 26 weeks. An interesting risk was further increased among those with progressive ventricular dilatation requiring intervention. And then this randomized controlled trials was published in 2018, where they randomized the patient when the ventricular index is at 97th centile. They randomized them to early intervention or the late intervention. In terms of early intervention, when the ventricular index was at 97th centile and the anterior horn width was more than 6 millimeters, they started intervening. Whereas in later intervention, was when the ventricular index was 97th centile plus 4 millimeter and the anterior horn width was more than 10 millimeter. And the intervention wise, they were doing lumbar punctures initially. If patients still having progressive ventricular dilatation, then they put the reservoir and tapping the ventricles through this reservoir, and if it does not settle down and patient continue having ventricular dilatation, then they get the ventricular peritoneal shunt when they reach to a certain weight. And really the outcome of this randomized control trial was that there was no significant difference in terms of ventricular peritoneal shunt or death in these two groups of patients. Either they were treated by early intervention or later intervention. The same group, then they tried to look at the brain injury and the brain volumes in this group of trial, in this patients in this group, and they did the sub-study. What they did MRI scan at equivalent age in these patients, and then they tried to score the brain injury and the brain volume using Kidocor score. And what they found that the Kidocor score was lower in low threshold group, which means it was normal or mildly increased. Comparing with, it was higher in higher threshold group, which was moderate or severely abnormal score, and the p-value was also significant. And they also found the ventricular CSF volumes were smaller in lower threshold groups. So the conclusion of that study was there were more brain injury and larger ventricular volumes demonstrated in the high versus the low threshold group. So these results were supporting the positive effects of early intervention for post-hemorrhagic ventricular dilatation. And the same group of patients in the ELVIS trial, they tried to look at the neurodevelopmental outcome at 2 years of 2 years of age. And when they looked at the they calculated the cognitive score and the motor score. It's one thing which clearly come up that the patients in the low threshold group having better cognitive and motor score compared to those who were in the higher threshold group. And interestingly, they also divided them those who were having who needed a shunt and those who do not need a ventricular peritoneal shunt. And the patients within the low threshold group having almost normal neurodevelopmental outcome. But patients in the higher threshold group who need a ventricular peritoneal shunt, they were having the worst neurodevelopmental outcome. In conclusion, that the earlier intervention was associated with lower odds of death or neurodevelopmental disability in preterm infant with progressive post-hemorrhagic ventricular dilatation. And then it comes up a meta-analysis was done, which was recently published, and they try to relate the timing of temporizing neurosurgical treatment in relation to shunting, ventricular peritoneal shunting, and neurodevelopmental outcome in the post-hemorrhagic ventricular dilatation. The aim was really to see if there any relationship between these, and what they found that the later timing of this temporizing neurosurgical procedure, it predicted higher rates of conversion of ventricular peritoneal shunt and moderate to severe neurodevelopmental impairment. And they use this graph to explain their finding. If you see that later the initiation of temporizing neurosurgical procedure was associated with higher rates of ventricular peritoneal shunt. And then they found the same kind of relationship between the neurodevelopmental outcome and the later initiation of the temporizing neurosurgical procedure. And then this study came up where they tried to look at the neurodevelopmental outcome in the same group of patients, those who were having post-hemorrhagic ventricular dilatation, and they were managed either by early approach, which means the intervention started when the ventricular index is at 97, above 97 centiles, or the late approach when the ventricular index is 97 centiles plus 4 millimeter. And they look at the preterm infant less than 30 weeks, a total about 127 and 78% in early approach and 49%. And what the conclusion was that those early approach group, even when they're requiring a shunt, had outcomes similar to those without intervention and being within the normal range. Whereas in late approach group, they need intervention predictive of worse outcome. And the benefits of early approach was really outweighs the potential risk. And if we look at their neurodevelopmental outcome a little bit closely in the same population, that most of patients who were having early approach, most of them were having quite high neurodevelopmental outcome, close to normal. And whereas we see those who were managed with late approach with intervention, their neurodevelopmental score, they were having maximum number of patients with moderately abnormal neurodevelopmental outcome. And if we see at the cognitive and the motor score, it is almost near normal in patients with early approach. Either they are without intervention or they having the intervention. Whereas in those managed with late approach with intervention, quite worse outcome. And then the impairment like having cerebral palsy, hearing impairment, vision problems, and epilepsy. There were maximum number of patients in those who had late approach and having intervention. They also tried to relate the neurodevelopmental outcome with the ventricular size. And there was a clear relationship between the ventricular size and the neurodevelopmental outcome at 18 to 24 months of age. What they compare was in patients in North American population where the patients are managed with late approach. They try to compare their neurodevelopmental outcome with patients in the Elvis trial. Either they were managed with early approach or they were managed with late approach. And there is a clear apparent, that's clearly obvious that the patients who were in North American group, they were having a lower motor and cognitive development. And if you look at the ventricular size, patients who were managed in the Elvis trial, even they managed with the late approach, the ventricle size was much smaller compared to the ventricular size in North American population. So all this evidence is supporting that we need to avoid the largest degree of ventricular dilatation. Now, at the same time that after going through this, I tried to get some idea about the ongoing practice in UAE. And then what I did, I spoke to main tertiary level neonatal unit and spoke to the chief. I collected some information about the management of post-hemorrhagic ventricular dilatation in extremely preterm infants. So if you look at this data, there's no much difference between the incidence of severe IVH and the rate of developing post-hemorrhagic ventricular dilatations. But the interesting thing is almost all the units have having very minimal number of cases to manage. So that might be related that it might be difficult to develop the skills which are necessary to manage patients with such problems. And if we see at the diagnostic criteria, then again the diagnostic criteria is related to being symptomatic or late approach, which means that the ventricular index is 97 centile plus 4 millimeter, or the head circumference is increasing more than 1.5 centimeter. And the intervention threshold, again, most of the centers were treating symptomatic patients, or if the ventricular index has reached to 97 centile plus 4 millimeter, and the head circumference is going faster than 1.5 center. And the CSF drainage modality which they were using were, again, most of them were doing the ventricular tap directly, or if they have got the arrangement, they insert the Ommaya reservoir. If the still ventricles are getting bigger, then they get the ventriculoperitoneal shunt. And then most of the centers are not having the neurosurgeon arrangement in the same hospital. So recently, comparing all this, a framework to approach such a problem has been published, which has been agreed by most of the people who have been managing these problems over years. And this framework is based on measuring the ventricles on cranial ultrasound, and then also taking into considerations of clinical signs of raised intracranial pressure. And then they also look at the head circumference growth as well. And based on that data, they were dividing them into 3 groups, either zone green, yellow, and red zone. And then they follow the recommendation. And that seems to be well supported by the evidence that when we are treating patients with post-hemorrhagic ventricular dilatation, the cure should help them to get a better neurodevelopmental outcome. So what we should do, I really leave that to decide with you guys that how we should manage post-hemorrhagic ventricular dilatation in this region. But what I think that we really need to have a multidisciplinary team approach. We need to agree on one clinical practice, and the one clinical practice which is well supported by the evidence is to monitor the dilated ventricles with cranial ultrasound, taking into account clinical signs and looking at the head circumference as well. And then then following this framework. And again, most of the centers haven't got enough number of patients. So the patient need to be referred to one center, and that center will have enough patients to develop the skills and manage the patient with one recommended approach. Thank you very much for having me. I'm happy to answer any questions if it comes up.
Thank you, Zandy. Thank you very much, Dr. Ali. You have to have some very important aspects and the local data you shared with us. I need you for a panel discussion. We have the neurologist from outside, and we all will have the panel discussion after our last talk. Last but not the least, very important, very interesting topic. Dr. Sarah Mulki, it's my pleasure to introduce her. She's the MD and PhD prenatal neonatal neurologist in the Division of Prenatal Pediatric and Children's National Hospital. She earned a PhD in clinical and transitional science to further support her development as a clinical researcher. Dr. Mulki is an active member of Society for Pediatric Research and the Child Neurology Society. Her clinical expertise and interest focus on abnormal development or injury to the developing brain. She has authored multiple peer-reviewed manuscripts of topics related to newborn brain injury, neuroprotection, neuroimaging of the newborn brain, and of neurodevelopmental outcome. He is currently the director of prenatal and neonatal fellowships, Children's National Hospital, Washington, D.C. She's going to tell us about congenital infectious encephalopathy, yet another very interesting topic. Over to you, Zandy, and then to Dr. Sarah Mulki.
Hi, thank you so much for having me speak this afternoon on congenital infectious encephalopathies. This is a very important topic to me. I've been very involved in the evaluation of congenital infections, especially since the Zika epidemic, and I'll talk a little bit about Zika at the end. But this is really a topic that I think we all need to think more about when we're seeing babies in the NICU. So I have disclosures of my grant funding related to Zika. So the objectives of the talk today, we're going to discuss why the term torch is outdated. And I'm going to hope that by the end of the talk, you will use different terms besides torch. And I would like to enhance your understanding of congenital infections and how they can really cause disruption to the developing brain. And then I'm going to talk about the presentation, diagnostic evaluation, and potential treatments of some of these congenital infections. I can't possibly cover them all today, though. So congenital infections are likely under-recognized, and because of that, they may not get treated. In some cases, they may be preventable. Just even simple things like encouraging pregnant moms to hand wash more may prevent congenital infections. And they can contribute to substantial abnormalities of the developing brain. So things like destructive lesions that we can see in the brain, such as intracranial hemorrhages, calcifications, reduced cerebral growth can be because of congenital infections. And then also brain malformations, which I see a lot as a neurologist. So things like schizencephaly or polymicrogyria, cortical dysplasias, these can be due to a congenital infection. And so while they can have other etiologies like ischemic injuries or genetic abnormalities, they can be because of infections. So we really need to be very thorough in our thinking of the etiologies of the different brain conditions that we see. And so I am a fetal neurologist, and so in my practice, I am referred many different kinds of cases for evaluation in which there's a concern for the developing brain by prenatal ultrasound. And while it may be hard to read all these different conditions, I want to show that really when I'm seeing a a fetus with a concern for a brain abnormality, that for many of the cases, I need to think, could this be a congenital infection? And so I often consider evaluation for congenital infections in my workups. And so the term torch no longer works in 2021. So this is an old term. It was coined in 1971. We all learned this term in medical school. And it used to be a convenient term because it worked with T for toxo and O for other, R rubella, C for CMV, and H for herpes simplex. But the problem is the other list has gotten so long, and as you can see on the left side there, many different viruses go underneath that other term. And of course, Zika was added to this list in 2016. And so there's really not a mnemonic to work to describe the different congenital infections. And so really this term is no longer accurate. And since 2014, certainly our infectious disease colleagues have recommended that we do not use this term. And I want to encourage you today to not use this term. And so what I recommend instead that is if a mother had evaluation for congenital infections, or you're going to evaluate for congenital infections in the baby in your NICU, that you specifically state what infections either the mom was tested for or the baby. And so no longer use the word torch titers assessed because we can't really know what that means, and probably not all of the things on the list were checked for. And so we care a lot about congenital infections because they can cause a whole host of sequelae to the baby. And so we can see that most of these, or all of them, really can cause intellectual disabilities. They can cause seizures, blindness, deafness, motor disabilities, learning disabilities. We can see limb deformities in some of them, and so Zika is one of the new ones that has been recognized to cause arthrogryposis. Cardiac dysfunction, hepatic dysfunction, and endocrine dysfunction. And so it's important to recognize these because some may have specific treatments and it really can affect the whole body of the baby. These congenital infections, some of them have given us some hallmark features to help us distinguish. So when we do our workup, we can really target for those that are most likely for our specific case. And so microcephaly, that is one that is more common with toxoplasmosis, rubella, definitely CMV, and of course Zika, but also varicella and lymphocytic choriomeningitis virus, which we'll talk about later in this talk as well. Hydrocephalus, that is one that toxo can cause. So while it can cause microcephaly, it can also cause hydrocephalus if those spores are blocking the circulation of the CSF. Zika can also cause hydrocephalus by a similar mechanism. And then the calcifications are an interesting feature of these congenital infections. So of the infections that have calcifications, they have a unique location based on the infection. And so the location of the calcifications for toxo is fairly diffuse around the brain. Whereas in CMV, the calcifications really line the lateral ventricles, and I'll show you what that looks like. In HIV, they can be more in the basal ganglia. And then in Zika, it's really in the subcortical region. And then hearing loss is a feature of several of the congenital infections. And so when we see a baby in the NICU that has failed their hearing screen, we need to consider whether this could be because of a congenital infection. And it may actually be the only symptom of the congenital infection. And so in this talk, I'm going to present a couple cases of different infections that have come to us just to really show how these can present. So this was a very interesting referral of a 29-year-old G3P2 mom at 20 weeks and 3 days into her pregnancy. She was sent to us because of fetal ascites, a placental abnormality, and a small fetal head. And the history was very interesting on this one. At 7 weeks into her pregnancy, and this was in the summer, she had a low-grade fever, fatigue, nausea, and headache. Her husband had the same symptoms for about a week. They had a 2-year-old daughter who's healthy. They hadn't traveled anywhere, and she was negative for COVID. So they pursued an infectious workup. Because they live here in the mid-Atlantic, they were tested for Lyme, and that was actually found to be positive. So She and her husband both ended up getting treated for Lyme, which is interesting because certainly it's carried by a tick. And so how the mom and dad would have that at the same time, I don't know. But they were treated for Lyme. Her varicella antibody was positive, but she had been previously vaccinated. Epstein-Barr virus was positive, but that was felt to be cross-reactive due to the Lyme exposure. And so those were the initial infections actually evaluated. And then it was a little bit later into the pregnancy, closer to when she came to see us, that someone checked for CMV. And if you recall the symptoms that she had, kind of that low-grade fever and malaise, that's really how primary CMV can present in an immunocompetent person, just like a cold. And dad probably had it too, which is why he had the same symptoms. So she was then referred to an MFM for evaluation of congenital CMV. At the MFM, initial fetal ultrasound at 15 weeks, the biometry was normal, but there was a small echogenic focus in the bowel. And then an ultrasound a few weeks later showed a significant drop-off in the head circumference and the biparietal diameter, with a thickened placenta and significant fetal ascites. They did an amniocentesis for CMV and referred her to us for further evaluation. And so here is the fetal MRI in this case at 20 weeks and 3 days gestation. And so this is an axial T2 fetal MRI. And so what we can see on this head is, so this is, so one side of the brain, actually the tissue of the parenchyma looks very dark and thin. And so this is injured cerebral cortex. On the other side of the brain, it's actually kind of thickened and edematous appearing. And so this is undergoing injury on this side. So almost kind of two separate time points of this injury progression for this baby. And we can see this again on this coronal T2. But this goes along with the microcephaly that the fetus is now showing with this smaller head size. When we look at a sagittal image of the baby's brain, we can see the corpus callosum is also short now, so its growth has been disrupted by the infection. And we also can use diffusion-weighted imaging in the fetus. And so we can see that that half of the brain that was showing as edematous is actually bright on our diffusion, so undergoing in acute injury. This is another image of this baby, and you could just see the massive ascites and enlarged liver. So this is a very sick fetus with congenital CMV. Here is an image of the placenta. It is very thick and homogeneous. So we also can do brain volume analysis in our cases. And so on the left side is the total brain volume. And I showed you on the images of the MRI, we could see that the tissue was thinned, and we know the baby's measurements were microcephalic. And so that correlates then with this total brain volume at 20 weeks being below the 2 standard deviation mark. However, the ventricular volume was increased, and this is because of the ex vacuo dilation of the ventricles because of the loss of the cerebral tissue with this infection. So the amniocentesis was positive for CMV, and this is primary CMV infection in pregnancy in a very severe case. When I consider babies with congenital infection, it is always important to try and get the placenta. And so if you do have a baby in your NICU that you're concerned about congenital infection, try and get that placenta if you can. So here is placental pathology from a different case, and we can see the inclusions of the CMV here with special staining in the placenta. So congenital CMV is the most common intrauterine congenital infection. It is very important because it causes a huge economic burden. 9,000 infants are affected in the US each year, and it's potentially 1% of all live births. Vertical transmission can occur to the fetus at any age in gestation, but the highest risk is in the first half of gestation. When a mom has the primary infection, like in this case, there's a 30 to 50% risk of transmission to the fetus. But there can also be reactivation. So having prior immunity to CMV does not remove all risk. So you can have reactivation of infection or exposure to a new strain of CMV during pregnancy. And for those cases, the risk of transmission is not as well known, but it's probably about 10%. And so CMV is passed from person to person through close contact with body fluids, saliva being the main one, but others as well. And so, in this case, the family had a baby in daycare, and so that may be they had a younger child, 2-year-old in daycare, and so that may be a source of exposure for a mother that is not previously immune to CMV. And so in daycares, excretion rates can be very high for CMV. So many children in daycare will have CMV at some point. And actually, a seronegative mother who has a child in a group daycare setting is at significant risk of acquiring CMV infection during the first year of their child being in that daycare environment. And so this is where preventative measures come in. And so encouraging hand hygiene after diaper changes. Any pregnant personnel should use universal precautions. And then, of course, if you know your sero status prior to pregnancy, you can advocate for increased use of these preventative measures if you know you're seronegative. So this is some nice work done by Dr. Britt looking at the risk of fetal infection and abnormal outcome during pregnancy, whether a mom has preconceptional immunity or does not. And so if it's a primary infection, as we talked about a little earlier, the risk of intrauterine transmission is about 30%. And of those infected, about 10% of newborns will have symptomatic disease, and 30 to 40% of those will be severe. But 90% of babies will be without symptoms. However, it's important to note of these 90%, about 10% later on will develop delayed sensorineural hearing loss or some developmental delays. But for moms that have had exposure to CMV before, and they either have reactivation or are exposed to a new strain, there is still the risk of intrauterine transmission. It is less though, but we don't know that exact amount very well. And if the baby does get infected, we feel that probably it's about 10% of newborns with symptoms, but probably less likely to have the severe disease. And so here, again, these are the calcifications in CMV. And so they really have a hallmark location of being along the lateral ventricles, which is different from the other congenital infections. So CMV diagnosis, it is critical that it's diagnosed early in life because it's outside in the community so much. So a baby that's left our NICU, if we want to test it then, we can't know that it was congenital CMV. So it really has to be diagnosed within the first 3 weeks of life. We usually do this by urine PCR. You could also go back and get the newborn blood spot. So we use a newborn blood spot for our newborn testing. And so that can be a source to check later after the 3-week period. And then we have treatment for it. And so this is one you do not want to miss because we can treat the baby with oral valganciclovir. And this can show a modest improvement in hearing and neurodevelopmental outcomes. They have to be monitored for toxicities and have follow-up audiology evaluations. But it's nice that we have a treatment to improve some of the outcomes for this specific infection. There is a lot of research going on for congenital CMV. For the postnatal period, that we're looking at some new medications, new antivirals, expansion of the treatment to asymptomatic infants. So currently only symptomatic infants are treated. And then we have a study going on at Children's National where if a baby has developed sensorineural hearing loss, we can go back even up to age 4 years of age and go back to that newborn blood spot to see if we find CMV, and we can provide treatment. So I'm going to go to another infection. This is a case that came to us at 29 weeks gestation. It was a homeless mother, and she had of the twins, one had very significant cerebral ventriculomegaly, and the other had normal brain. And so on this one twin, there was extensive loss of the cortex and white matter. It looked very much like a vascular type of injury. The babies were born near term and actually transitioned pretty well. The placenta had some finding of chronic colitis of unknown etiology. There was testing at birth for congenital infections, kind of the standard ones we thought of, and those were all negative. And so here's the fetal MRI, in this case at 29 weeks. And this is such a nice image because we can see a sagittal image of the brain in both twins. And you could see the normal twin here with the brain that is very full, no abnormalities, compared to this twin in which the brain parenchyma is severely atrophic, and there is a lot of additional fluid around the brain, and this injury that looks pretty chronic at that point. Here's a coronal image of this fetus again. You could see just very severe loss of the cortical mantle. Postnatally, we could see some calcifications in this case, which were not apparent in the prenatal period. And again, the brain is just very, very atrophic. So this baby came in at a few months of age with concern for seizures, which with the abnormalities of the brain is certainly a baby at high risk for seizures. They did some additional evaluation at that point, including hearing, which was normal, but also an ophthalmology evaluation. And they found these diffuse pigmentary changes throughout the macula that were concerning for congenital infection. And so the earlier infections we checked for were negative. And so we thought some more about this, and LCMV was checked for, so lymphocytic choriomeningitis virus, and was found to be positive. And so this is a single-stranded RNA arenavirus. The common house mouse that is present throughout the world is a natural host for it. It is shed in large amounts in the urine, feces, saliva, and nasal secretion of these little animals. It can also be in hamsters. And then humans acquire it via inhalation of aerosolized particles. And then when the mother is viremic in pregnancy, it can have transplacental spread. Many times a woman can be asymptomatic, or it can present as an aseptic meningitis. But the congenital infection can be quite severe, like the case that I showed you. And we can see just severe structural brain abnormalities, microcephaly, calcifications, retinal damage, even isolated cerebellar hypoplasia can be because of this. So it doesn't have to involve the whole brain. Sorry. There is no treatment available and only supportive care. But LCMV is present throughout the world. The adult seroprevalence is 5%. So really we should be thinking more of this virus. Sorry. So I'm going to go on to another infection. This is a fetus that presented to us with cerebellar hypoplasia following fetal anemia. So this woman had a pregnancy complicated by fetal ascites, which is found to be due to human parvovirus B19 infection. There was anemia found at 21 weeks on the Doppler ultrasound, so she underwent intrauterine blood transfusion. And at 23 weeks, the cerebellum was found to be hypoplastic on ultrasound. So she was referred to us for fetal MRI. And so these are images of the fetal brain. And so here we can see the cerebellum, which has a normal contour. But here in these MRI pictures that are taken later, we can see this irregular contour of the cerebellum, so indicating an injury to the cerebellar tissue. This is a postnatal brain MRI now, again showing the abnormal cerebellum. And this is because of parvovirus B19 infection. So parvovirus exclusively infects humans. We get it from contact with respiratory secretions and blood. It is pretty common, so 50% of adults have been exposed to this. But again, we get it from those childcare settings where we could be exposed to this virus, and in the US in the springtime is the common time for being exposed. The presentation of this, women, the risk for transplacental spread is about 30% during pregnancy. The highest risk to the fetus for fetal death is in the first trimester. And we worry a lot about severe fetal hydrops. It is about 10 to 20% of all cases of non-immune hydrops vitalis are because of this infection. And this infection can cause significant injury to the brain, and so we can see calcifications, white matter injury, cerebral infarction, again, cortical dysplasias, heterotopias, and polymicrogyria, all those brain malformations that I worry about and see in my neurology practice can be because of this infection. There is no specific treatment for this, and so again, frequent hand washing to prevent infection, especially in pregnant women. So congenital toxo, always on our list of considering congenital infections. It can be asymptomatic at birth in quite a bit number of cases, and we know it can cause a significant neurologic conditions in the child. Intellectual disabilities, developmental delay, and then microcephaly and hydrocephalus that we talked about. And I want to show in this image below that the calcifications with this are really diffuse, as opposed to where when we saw in the CMV case that it lines the ventricles. So congenital toxo is one also very important to consider because we do have a treatment for it. And so in the prenatal period when it's diagnosed, you diagnose it with serology. In the US, we have a specific lab we send it to in California. And the testing is actually very good for this virus. Treatment prenatally is spiromycin, which is very good at reducing the transmission from the mother to the fetus. And so 23% transmission in treated mothers compared to 60% of untreated mothers. Postnatal treatment is continued with pyrimethamine, sulfadiazine, and fulinic acid for a year with close monitoring. And then we'll touch on our last infection here. So this is a case of fever and a rash illness in pregnancy. A woman, sorry. A woman who traveled to Belize and Guatemala and Cancun in her first trimester of pregnancy. After returning to the US, she developed an illness lasting 5 days with a low-grade fever, an erythematous maculopapular rash, myalgias, and photophobia. Her husband also developed similar symptoms. So after returning from her trip, obstetrical evaluation was normal. But then a few weeks later, the ultrasound was still normal. She was assessed for Zika because of these symptoms, and these returned as positive. At 19 weeks gestation, which is now 7 weeks post-symptoms, the fetal ultrasound became abnormal, and she was referred to us for further evaluation. So this is a fetal MRI at 20 weeks gestation in this fetus. And this is actually probably the first reported fetal MRI of Zika virus infection. In this image on the left, which is a normal the case at 20 weeks gestation, we can see that the cerebral cortex is severely thin, especially in the frontal lobes, compared to the normal fetus at 20 weeks, where we have a nice thick cortex and a present lamination pattern. This is the same fetus at 20 weeks now on a sagittal image, and we can see that the corpus callosum is quite small in the image on the left compared to the normal corpus callosum in the image on the right. And actually, if you recall back to that CMV case that I showed you at the beginning, we actually have some similar findings between these two cases. And so this is from Zika virus. And so we know this is a virus fed by mosquitoes, and it is related to dengue and West Nile virus. This virus had actually been around for a very long time, but it wasn't until it caused the devastatingly high rate of microcephaly in Brazil that it was recognized to cause a congenital infection. And so congenital Zika syndrome is the severe clinical phenotype of congenital Zika infection. What we see is children, of course, with microcephaly because of very severe disruption to brain growth after the infection, hyper or hypotonia, arthrogryposis, developmental delays, ophthalmologic abnormalities, and sensory neural hearing loss. And it's about 5 to 12% risk after in utero infection. So there's very high risk for this very severe these manifestations. And what it seems mostly is that there is a very severe manifestation, such as what we're of this list here. But the other children that are exposed seem to do pretty well. And so there are some very unique features of congenital Zika syndrome compared to the other congenital infections. So they can have this abnormal skull shape, and this is because of a condition called fetal brain disruption sequence, where the brain growth or the halting of brain growth is so abrupt that the hydrostatic pressure of the brain inside the skull is altered so rapidly because of the destruction of the brain tissue that the skull collapses downward, causing this occipital protuberance. The cerebral calcifications in Zika are in the subcortical region, so different from the other congenital infections. They can also be in the basal ganglia region. And then Zika can cause arthrogryposis. None of the other congenital infections do this. Zika can also cause significant eye findings. So many different kinds of eye findings can occur. So chorioretinal atrophy, optic nerve abnormalities, iris colobomas, lens subluxation. There can also be sensory neural hearing loss. But unlike CMV, that is, it's either present at birth, but it does not occur later. They can also have seizures. They can also have cerebral infarctions or vasculopathies associated with the infection. And then, of course, there can be the other sensory polyneuropathies that are seen in older infants and children. And so here is a case that came to see us at 25 weeks gestation, showing all of these features of congenital Zika syndrome in a fetus. And so we have a very thin cortical mantle, a fetus with arthrogryposis. You can see ventriculomegaly because of the loss of the brain tissue. And this is the ultrasound growth curve of the head circumference, and it's below the curve. And so while we're not hearing much about Zika now, it is circulating in low levels in these same areas, Central and South America. And so we just need to be cognizant of thinking about it if we are seeing a baby with microcephaly and the family did travel. And so what's I think important for us to be thinking about as we're moving forward from the Zika epidemic is certainly that, there are a number of babies affected at birth. So about the 10% of babies whose mothers had the infection in pregnancy have birth defects because of Zika, microcephaly, and these children will have abnormalities in their development. But what we're starting to understand now, and we have been working a lot on over the last couple of years, is of those healthy babies, or the 90% of babies whose mothers had Zika infection, are they going to go on to be affected and have differences in their neural development or stay healthy? And so data that I worked on in my group in Colombia and also in the US is that these babies, at least at 18 months of age, were showing some signs of having lower neurodevelopmental scores, even though they were normal appearing children. And so just to highlight our congenital infection program, we have a multidisciplinary program with innovative research, a wonderful process for supporting these families throughout the pregnancy and our advanced imaging. And we evaluate many different kinds of congenital infections in our program. I think they're all very important to consider as potential etiologies for a lot of the brain conditions that we see. And that's the end. So, thank you.
Thank you, Eamon, Sarah, and Suma and Ali. Very fruitful and extensive neurology session. So again, I will do like Eamon, one by one. I will ask a question. So the first question for Dr. Eamon Ramani. There is one thing you said in your talk that do not wake the baby up and sleep. So what about the feeding? Because this is the common practice that they wake the baby for the feeding. And not only that, if the baby taking the feeds and go to sleep, so what they will do, they will put the hanky and begin the rest of the feed. So what do you think about that?
So initially, if you feeding the babies for like every 2 hours, it's not really you have to do it every 2 hours.
Yeah.
And you can actually, if you're feeding by in G tube or OG tube, you can feed without waking up the babies because you don't have the cues to be developed at that time which give you indication that the baby is hungry. When the baby gets older and you get flexible like timing between 2 to 3 hours, you can wait a little bit if the baby is sleeping until they wake up. And the best time to feed the baby is when they're actually kangarooing with the mother. So this is the best time when you feed the babies, and this is actually time when the baby sleep. The baby can fall asleep, and then they can be fed during sleep. When I'm talking about waking up the babies, is that I don't know if we bundle the care enough in our units. When you have multiple disciplines, examining babies and at certain different times. So what we're trying to do in our neuroprotection unit is that to bundle the care. So you do waking up the baby once for examination by physician, nurse, respiratory therapist, and you bundle everything together. So we don't have to disturb the sleeping too much.
Sure. Okay, my next question to Suma for you. NIRS, actually it's a very new here. I am not very humble to say I'm the first one who start using it. I'm very much convinced about, but just for the our audience and our participants, how you feel. I know you talk about it, but how you feel. It should be like a standard of care. It should be more evidence in this technology support. What do you think? And this is a question for a lot of audience from the audience.
Absolutely. That's a great question. I think that at this point, I don't think it should be the standard of care for every neonate in the NICU because, really pointing to what Dr. Hani said about, trying to have natural care, kangaroo care, NIRS would interfere with that. But I think there are specific populations that certainly can benefit significantly from that additional monitoring piece. So I think when you develop algorithms in your unit, looking at what is the population at highest risk and what are the times where they're at highest risk for adverse brain injury, and then can we add this monitoring at those time points in those specific populations. It also needs to be followed with a clinical algorithm for response to the numbers that you're seeing versus just things, I've seen it used in NICUs where people almost ignore the numbers and don't respond to it, and that's not what you want. You want it to be a useful piece of information. So it has to be incorporated into the overall care of the baby, presented on rounds and such.
Thank you. I will come back to you, Dr. Ali.
Yes.
You talk about multidisciplinary team approach, but the question is that we have different approaches and the neurosurgeons are involved. Do you think the decision-making power in the management of post-ventricular hemorrhage is the neuropediatric neurosurgeon or is it the neonatologist? What do you think? I know MDT approach, but still these things are going on. And I need the comment of Dr. Ayman on that also after Ali.
Well, I think, and that is the international practice, is that these babies are in the neonatal unit and they are managed by the neonatal neurologist. So the practice stays with the neonatal neurologist. For example, I was working in Bristol with Dr. Whiteline Southmead. They are the people who lead the team, and the neurosurgeons do contribute into it. They do have the say, but they have more say in terms of doing neurosurgical procedure. But when the intervention is needed, that is with the neonatal neurologist. But if you remember in my talk, I showed one framework at the end, and that framework has been agreed by the most of the internationally renowned neonatal neurologist and the pediatric neurosurgeon. I don't think there's another approach at this moment. New things may come up in the future. That's a different thing. But at the moment, the standard approach is only one, which is early intervention at early stage, taking into account ventricular index at 97 centile and the clinical signs of raised intracranial pressures and the head circumference. So that's the framework which we all need to follow. And it is related to the neurodevelopmental outcome, which has clearly come up. The neurodevelopmental outcome is not good in those who are managed at late at late thresholds.
Yeah. So Ayman and Soma and also Dr. Sara, if you can, all three can comment on that, because this is a very hot topic here in UAE, the post-ventricular hemorrhage management. So Ayman, what do you think?
I think the first thing that you start with is to have a guidelines that to have a standardizing the care, because you have different, even neonatologists, different training, different backgrounds. They all have this different ideas about when to intervene, how to intervene, and all that. So in our unit, we kind of sat down and say, okay, this is the guidelines that we're going to follow. Now, the decision to intervene, actually, it's a shared decision. It's not really one or the other. It's the neonatologist will initiate the monitoring, when to do the ultrasound, how to interpret the ultrasound. And we sit down with the neurosurgeon and he will say, okay, so this is now we reach a threshold. And Dr. Rafiq mentioned, there's no one way to proceed with the procedure. You try the repeated LPs and you have a 30 to 50% chance that we will have arrested hydrocephalus. That's not going to be, we need to be, to have a hardware installed in the brain. And, and then when you get some device to be implanted, then you talk to your surgeon and they're going to be individualized according to the baby. Because some babies, Ommaya reservoir will not be an option. It depends on the skin, depends on the skin condition, depends on the fragility of the skull and all that. Then you have to explore other options. Some, you use externalized shunt, some use Ommaya reservoir as temporizing until you get to the VP shunt. So it's all a shared decision, and you have to include the family in the decision, because when you have a decision to put a VP shunt, that's not really the magic solution. You open a lot of problems in the future, with the infections, with the obstructions, with the issues. So that's that related to hydrocephalus. I just want to comment on the NIRS with Dr. Suma. We use NIRS in our unit, and we use it in selective cases. We don't really use it on everybody. We use it when we actually have, for example, like a PDA, we're not sure if it's really significant or not to treat. Or we have it as a kind of tool to tell us during blood transfusion if we really want to stop feeding or not to stop feeding. So I'm not really in favor of putting NIRS on everybody, because it becomes a number that's going to be meaningless and nobody will look at it, as you mentioned. So it's one tool that we use just to kind of add to understanding, because sometimes we use the blood pressure, for example, parameters that really doesn't make any sense, but related to, for example, what's mean equal to gestational age. This didn't come from any evidence based. So if we have a low blood pressures, we say, okay, well, if you put in years and it's affecting that blood pressure need to be treated. Otherwise, we're just going to write it out and then babies look at the other parameters like acidosis or something like that. So it's selective cases. I agree with you.
Sure.
Now, selectiveness that, you know, the perinatal transition where they're at the highest risk for IVH development, you know, really could be, and that's where a lot of research has focused. And I think that could be an area of routine monitoring. And then it comes off unless you have those situations that you mentioned, could be a way to go about it as well.
Okay. Dr. Sarah, you mentioned about the CMV treatment. Can you elaborate a little bit more about the targeted treatment on bezancloprid? For 4 months, you put it in your presentation, or 6 weeks. We are usually treating for 6 weeks. Can you elaborate on that?
Yeah, so it's so that's for symptomatic babies. So I think I presented some data on some of the studies that are looking at some different time courses of treatment for asymptomatic children. But for the symptomatic children is what we do for the 4-month treatment.
Okay. Okay. I'm sorry because I have questions. I think I will email to you, all of you, because the organizers are saying that we are delayed because the next session is going to be started because they are from the different countries. Thank you very much, Dr. Sarah, Dr. Suma, Dr. Eamon Rahmani, and Dr. Ali Raza. Very well organized your talks, and we learned a lot from your this session of neurology. And I'm sure I will ask them to send all the questions to you, especially to Dr. Suma Hoffman and to Dr. Sarah, because these are the two very hot topic areas and the infection, and you will get some emails. So please don't mind if you answer those.
Oh, great.
Eamon and Ali, I can ask them later on. I will email them. So that's not it. Thank you so much. Thank you.
Thank you.
Thank you very much.
Thank you.
Thank you.